I was really impressed. Yeah, maybe we'll start with the less common long-term adverse effects, but certainly a concern with regard to our high-risk patients who receive anthracycline-based therapy and then who go on to receive myelosuppressive or myelo-altering therapies. This was a concern for PARP inhibition, is the development of secondary myeloid disorders like MDS or AML. And I was impressed by the lack of identification of a higher risk of developing myeloid disorders or cancers in the longer-term follow-up of OlympiA. In fact, I think numerically the number of AMLs was slightly higher in the control group. And so do you buy this? What do you make of sort of long-term risk in terms of, let's start specifically with myeloid disorders?
Well, I mean, yes, I mean, you outlined the observation, and it's the same from the metastatic trials, which was there really wasn't a significant number of AML MDS that could be associated with the PARP inhibitor. There is a definite increase in risk, but it seems that a lot of that is coming out of the ovarian population. And this is completely speculative, but the ovarian population would often get repeated exposure to carboplatin before they would wind up getting a PARP inhibitor. And at least in days gone by, a lot of the breast cancer patients did not.
Yeah.
And so whether or not our embrace of platinum-based therapy, or at least our temporary invasive platinum-based therapy for triple negative, is going to have an impact on this later on remains to be seen. But at least so far, with the therapies that were being used during the OlympiA era, that wasn't being seen. No increase in risk with that. And no increased risk of other malignancies either.
Yeah, and taking that point even further, I think looking at secondary or second primaries, both in terms of breast as well as ovarian cancer risk, we saw a reduction in those risks in the OlympiA trial, as I think we would anticipate.
Right.
So perhaps a secondary benefit for this high risk group, genetically speaking.
If I can comment on that, I mean,
Yeah,
it was a numerically lower risk. That is true. There were still ovarian cancer cases in the OlympiA group, in the PARP inhibitor group, and during the course of the trial, nearly half of the women underwent bilateral mastectomy, and something like 79% had undergone oophorectomy. So we're not going to really be able to get a great look at the true preventive effect of Olaparib in this population. And unless we did, I would be particularly nervous about counting on it to do ovarian cancer risk reduction. I think, unfortunately, we still need to be recommending preventive oophorectomy, maybe salpingectomies, to particularly the BRCA1 carriers who are at risk in this age group.
Such an important point. Thank you for highlighting that. I'm certainly recommending, as you pointed out, BSO in this high-risk group, despite the use of a PARP inhibitor. Do you think that you mentioned the breast cancer risk, at least for second primaries? Does this impact in any way your counseling with regard to the surgical decision in terms of prophylactic mastectomy?
Not really.
Yeah.
I mean, I think the surgical decision about prophylactic mastectomy, in my experience, is not conditioned upon a particular level of risk. I mean, it's a shared decision with a patient about her tolerance for the fact that she is at increased risk, full stop.
Yeah.
And, I have yet to see a woman who would make a different decision if you told her risk was 20% or 25%.
Right.
So once you exceed some certain subjective level of risk, people are going to do it. And unless you can guarantee them that the preventive approach is going to give them zero risk, I'm not sure it's going to impact their decision making.
Fair. Yeah, I think that's a very fair point. And I sort of view this almost as icing on the cake, if you will. We're certainly treating the primary breast cancer, but perhaps having some additional preventive benefit as well.